Good evening, everyone. It gives me immense pleasure to welcome you all to the first session of GynoScope, a collaborative academic initiative brought to you by Dr. Aditya Nimbkar and the academic team of SIMSOG. The name GynoScope was carefully chosen. Just like a telescope gives us a deeper view into the universe, GynoScope is meant to offer a focused, insightful view into the vast field of obstetrics and gynecology. This unique series was envisioned with a singular goal: to create a space where young medical minds can come together to learn, question, and grow in the field of obstetrics and gynecology. And it has only been possible through the unwavering support and constant encouragement of Dr. Nimbkar, whose dedication to teaching and mentoring is truly inspiring. Dr. Aditya is an assistant professor at St. G.S. Medical College and KEM Hospital, Mumbai, and a passionate educator in obstetrics and gynecology. Having done his undergraduate from the same college and MS in obstetrics and gynecology from Lokmanya Tilak Municipal Medical College, he actively mentors young ObGyns through social media and a 5,000 plus member WhatsApp channel. He has authored an ObGy book, contributed to 8 textbook chapters, and published 18 research papers. Committed to improving clinical practice in education, he regularly conducts free academic sessions and is increasingly focused on fetal medicine alongside his core ObGyn interests. Through GynoScope, we aim to bring you a range of clinically relevant case presentations, real-time discussion, quiz-based learning, and unique formats like Dr. Nimkar's Brain Benders, which have now become a favorite among many of us. We're so grateful for the enthusiastic participation from colleges across the country and for the opportunity to help bring a stronger, more connected academic community together. Please note, the presentations will be judged by Dr. Aditya Nimbkar, and a cash prize of Rs 5,000 will be awarded to the winning team. The evaluation will be based on the following scoring parameters, each being out of 10. First one being history, second, examination, third, management and understanding of the topic, fourth, communication, fifth, higher order thinking. We encourage all teams to prepare comprehensively and present with clarity and confidence. Best wishes. Once again, thank you for joining us today, and we look forward to an engaging session ahead. Over to you, Dr. Nimbkar.
Hi, thank you so much. First of all, this is my second association with SIMSOG, the first one being the last one in December, where we had taken those sessions on theory and practical exam preparation. So I hope this series of 12 sessions, a marathon, kind of a marathon, is going to be fruitful for everyone who is going to be attending. A side note, a bit of I don't know, should I be calling it apologies from our end for a couple of things. First of all, for late joining, I take it for myself. There was a bit of technical lag from my end. And secondly, given that there has been an overwhelming response, even the server has been quite overwhelmed, I believe. And hence, it's a limitation that despite it being only 100, we had mentioned 100, you still admitted 150. I see that there are still 7 slots left, so your colleagues, whoever are pending, can join in. But then that is going to be the case henceforth as well, that the first 150 people who join in will be able to log in. Unfortunately, the rest will have to um, log in for the subsequent session. So without further ado, can we begin this one? Kashish, Rajlakshmi, are you all ready?
Yes, sir.
Okay, I hope you have been informed about the parameters, the 5 parameters on which I'll be scoring you.
Yes, sir. We know about that.
Okay, great. Okay, great. So now we'll follow this pattern across all the sessions. You first quickly, within like 4 to 5 minutes, swiftly breeze through the case, read it out completely from start to the end, and then I'll again get back to your initial slides and we'll go one by one so that people have an idea about what your entire case is about initially. So within 4 5 minutes, quickly just read your case out.
Okay, sir.
Okay, begin. All the
Okay.
best.
So, hello everyone. This is Kashish Akhtar, and I am here with my friend Rajlakshmi Pillai. We are from DY Patil Medical College, Pune, and we are here to present you a case of a heart disease in pregnancy. So, let's get started. So, my patient is 33-year-old married female from Alindi. She is a housewife and she has no official education as per, and she is a multi-gravida. Her obstetric score is gravida 3, parity 2, living 2, and abortion 0. Currently, her gestational age is 36 weeks plus 1 day. Now, coming to the chief complaints, she has a chief complaints of chest pain and breathlessness since last 15 days. And my patient was apparently asymptomatic 15 days back when she presented with the OPD with the chief complaints of chest pain, which was acute in onset, squeezing type, site which was central, non-progressive, and non-radiating in nature. It was aggravated on bending forward and relieved on lying down. No medications were taken. Uh, for breathlessness, it was aggravated on moderate activity, relieved with rest, with NYHA grade 2. No diurnal or positional variation was seen. There was no history of nausea, vomiting, and headache. Now, coming to the history of presenting pregnancy, my patient is married for 11 years and has 2 previous pregnancies. Current pregnancy was accidental and not planned. It was confirmed on urine pregnancy test after a month of amenorrhea. She is facing breathlessness and chest pain in her third trimester, because of which she visited the OPD. She was given aspirin and ecosprin for the same. She didn't get products of conception karyotyping or partner karyotyping done. She was started on folic acid. USG was done. There was routine ANC baseline investigations which were done prior. And patient is admitted currently and is under supervision. There is history of lethargy and constipation. There is no history of genital ulceration, generalized rash, or lymphadenopathy. There's no history of polyuria, polydipsia, polyphagia. There's no history of thrombosis and clotting disorders. No history of any trauma, irregular menstrual cycles, or burning micturition. The drug history, coming to the drug history, she has been taking tablet ferrous sulfate twice a day and folic acid with vitamin C, labetalol 100 microgram BD, and aspirin and ecosprin has been given to her. Coming to her obstetric history, she is a multi-gravida with G3P2 as her score, A0 and L2. Patient conceived spontaneously and was detected on UBT at 1 month of amenorrhea and is a registered case. Her last menstrual period was in 24th October 2024, and her expected date of delivery is 31st July 2025. Her present gestational age is 36 weeks and 1 day. Um, Coming to the present pregnancy history, or we can say trimester history. So, in the first trimester, there was no history of fever or rash, no history of drug radiation exposure, no history of excessive nausea and vomiting. Folic acid tablets were taken, and she received her tetanus dose 1 at 1.5 months, and level 1 scan USG were done. There were no history of bleeding and spotting. In the second trimester, quickening was felt at 16 weeks. Calcium and iron supplements were started. There were no history of polyphagia, polydipsia, or polyuria. There was no history of headache, blurring, and vision, or leaking per vagina. Then she took her second dose of tetanus in her second trimester. Level 2 scans were performed, and in third trimester, the routine blood investigations were performed. Fetal heart sound is normal and were tracked. Fetal movements were tracked, and non-stress test was performed. Coming to the previous history of the pregnancy, history of previous pregnancies. The first pregnancy was in 2016. She delivered a healthy boy through normal delivery at term, weighing 2.5 kg, which was breastfed immediately after birth. The second pregnancy was in 2020, where a girl child of 3 kg was born through C-section and kept in NICU after birth and breastfed after 2 days. Menstrual history. She achieved her menarche at 12 years and regular cycles lasting for 4 to 5 days. She used 1 pad per day. There was no history of dysmenorrhea or clotting. Marital history, she is married for 11 years at the age of 22 years, which was non-consanguineous, and there's no history of contraceptive use. Coming to the past history, she's a known case of rheumatic heart disease and was diagnosed in 2021 when she came with the chief complaints of involuntary jerky movements of the left upper limb and lower limb, which was associated with pain in distal phalanges, wrist joints, knee joints, and ankle. She also has a history of hypertension since 1 year and is on antihypertensive medication. She's non-compliant and poorly controlled. There's no history of tuberculosis, diabetes mellitus, epilepsy, or asthma. There's no history of any surgery except for C-section. Personal history, her diet is mixed, appetite is sufficient, sleep is adequate, bowel, she has been complaining of constipation for the last 2 days, bladder habits is normal, addictions, she has been eating mystery for the last 20 years, and there's no history of smoking or alcohol consumption. There's no significant family history. So my provisional diagnosis is that Mrs. X G3P2L2A0 at the gestational age of 36 week 1 day, having a long-standing rheumatic heart disease with a history of hypertension since 1 year, came with the complaints of chest pain and breathlessness since 15 days in her third trimester and is currently not in labor. She is a case of high-risk pregnancy. Now, I'll hand over the general examination part to my friend Rajlakshmi.
Hello everyone, am I audible? Okay, so moving on to examination, general examination. Patient was conscious, cooperative, and well-oriented to time, place, and person, and was examined in a well-lit room with proper exposure and prior consent. Height is 152.4 centimeters, weight is 64 kgs, and BMI is 27.6 kgs per meter square. Temperature is febrile. Pulse rate is 84 beats per minute, taken in left radial artery, normal volume, rhythm, and character. BP is 110 by 80 mmHg. Respiratory rate is 16 breaths per minute. JLP is 6 centimeters of water. Pallor is present. Icterus, clubbing, cyanosis, edema, and lymphadenopathy is absent. Breast is bilaterally symmetrical, no engorgement, discharge, or nipple retraction. Now, systemic examination. Serious inspection, chest is symmetrical, no precordial bulges seen, no distended veins or scars seen, apical impulse not visible. Palpation, apical impulse felt at the left fourth intercostal space parasternally, no parasternal heave seen, no abnormal pulsations felt in the epigastric region. Percussion, right heart border retrosternal, left heart border corresponds to the apex. Auscultation, S1, S2 heard, systolic murmur heard, grade 3, no thrill, best heard in the mitral area and lateral position. Respiratory system, bilateral air entry, vesicular sounds heard. PNS, no focal neurological deficit. Now, per abdominal examination, inspection, abdomen was uniformly distended, having linea nigra and striae gravidarum centrally placed umbilicus, flat, no distended veins, sinuses, fistulas. Previous C-section scar mark seen in the pelvic region. Palpation, no tenderness. Fundus corresponds to 36 weeks of gestation. Symphyseal fundal height 36 centimeter. Longitudinal lie. Irregular, broad, soft, non-independently ballotable structure present in the fundal dip, most likely to be breech. Irregular knobby structures present in the right side, most likely to be limbs. Smooth curved structures present on the left side in lateral grip, most likely to be back. Globular hard independently ballotable structure present in the pollix grip, most likely to be head. Hands converge in the deep pelvic grip, confirming the findings in the third grip and indicating that the head is not engaged. So to summarize, Mrs. X, 33-year-old female, housewife, resident of Alandi, Pune, has an obstetric score of G3P2L2A0. Her LMP 24/10/2024. Her estimated delivery date is 31st July 2025. And period of gestation is 36 weeks plus 1 day. She presented with a complaint of chest pain and breathlessness since last 15 days, which was insidious at onset, non-progressive, non-radiating, squeezing type of pain, and breathlessness was categorized NYHA grade 2 in the third trimester. She is known case of rheumatic heart disease diagnosed in year 2021 and hypertension, which was diagnosed 1 year back, is on medication for the same. On examination, mid-diastolic murmur was heard, suggesting of mitral insufficiency. On obstetric examination, gestational week was confirmed to be 36 weeks with the longitudinal lie, head not engaged. Provisional diagnosis, high-risk pregnancy due to rheumatic heart disease.
Great presentation, Kashish and Rajlakshmi. Well presented. So your case is a very classical case. By the way, I would just want to ask students, are they able to answer in the chat? I'm not sure if they're able to use the chat section. Just let me know in the chat if they are able to utilize it. If not, just let any one of us know on WhatsApp. Yes, available. Great, great. Okay. So, Rajlakshmi, Kashish, I'll begin, and either one of you can answer. There's no need to be systematic about it. First of all, could you just go to your demographic details?
Okay, sir.
Okay, so could you tell me what is the relevance of demographic history for all those who have joined? Just by the way, for all those who have joined, I would just want to share my notebook right now. And I'll just let you all know of a very common pro forma or a very common mode of putting your history forth in practicals. First of all, I hope my screen is visible now. I've put up my screen. So the format that was used by Kashish and Rajlakshmi is ideal. In your basic history, remember that primarily you get your demographic.
Sorry to interrupt.
Sorry.
So yes,
Yeah.
now your screen is visible, sir. Yeah.
Okay, it's visible right now. Yeah. Okay.
Yes,
So,
yes, perfect.
whenever I'm going to be talking about any history in obstetrics, remember that my first important part of my history is always going to be my demographic details or my demographic history. And in demographic history, apart from my name, which ideally I would want to conceal, now this is one issue with a lot of students in their exams in final year MBBS for any subject, medicine, surgery, obstetrics. Kindly refrain from telling the name. You might have consultants who might prefer otherwise, but then remember that mentioning the name of your patient is going to be revealing their identity, which you wouldn't want to do. So put it as a neutral thing, the patient. Don't even say my patient. A few people, a few consultants do get offended with that. It's never your patient. It is a patient in the hospital. And so the patient and the age and followed by parity status, marital status, residency, where they stay, and the occupation, very important. Following the demographic history, we'd be moving ahead to, in the demographic history, by the way, we are also going to be talking about the parity. Once the parity and everything is done, then I'll be coming to presenting complaints. Now, in presenting complaints, there is one thing that I personally prefer. And that is, I would want you to mention the 4 cardinal complaints of pregnancy first. So what are the 4 cardinal complaints of pregnancy? So the 4 cardinal complaints are pain in abdomen, leaking per vaginum, and bleeding per vaginum. And so yeah, so these are the 4 major complaints that you have to be showing, that you have to be mentioning in your history. Secondly, apart from that, bleeding per vaginum, decreased fetal movements, these four complaints should come at the beginning, and then you should be proceeding with your history-specific complaints. I mean, in her case, it is heart disease, and that is how we proceed. But for now, the demographic details. So, could you tell me what is the significance, what is the relevance of your demographic history in this patient? Rajlakshmi?
Yes, sir. So the major significance of the demographic details, especially over here, is that certain diseases are prevalent in certain economic status or strata. We can say that. So, knowing the history of this patient, she comes along through a lower middle class background, and she is a resident of Alindi, where there is a prevalence of rheumatic heart disease, or there is a prevalence of streptococcal infection. So that can be
Okay.
relevant.
Okay, so you are mentioning about the place of residence and the age as well. Okay. Would you want to just say that it is specific to R&D, or would you want to just say that it is something that is common with the subcontinent in general?
So I guess it can be generalized to the subcontinent as well.
Okay. What is the difference between the subcontinent and its Western counterparts then?
Sorry, sir. I'm not really
Um,
sure about this.
Okay, Rajlakshmi, would you want to attempt that? What is the difference? What are the various disorders of heart that you would see in our subcontinent in India in comparison to what would you rather see in the Western countries, the more developed countries like the United States or the United Kingdom? Anything?
Sorry, sir, I'm also not sure about that.
Okay, so see, there are a few important things over here. We might take a lot of pride in calling ourselves a developing country, but technically speaking, if I'm going to be talking about two strata, it is still underdeveloped in comparison to all our Western counterparts. And when I say underdeveloped, I intend to say that there are two things that are still not going great for us from a cardiac point of view. First of all, the incidence of rheumatic heart disease is very common because of the unhygienic conditions and the overcrowding of people, the way our living conditions are in India. So first of all, that is the reason why rheumatic heart diseases are much more common. Whereas in the Western countries, while this is not a problem, but the commoner problem is first of all because of consanguinity and also because of the relatively lower incidence of RHD, the incidence of other congenital heart defects increases. So RHD, which was classically inherited throughout life, that was inherited by these people, whereas in the Western countries, these people have a higher incidence of CHDs, congenital heart diseases, things like tetralogy of Fallot or something like transposition of great arteries, all these things. But also, when I say development, it also means that these countries, like the United States or the United Kingdom or all the European countries, they are much more adept at making these patients survive. They are able to operate on them and they are able to give them a longer lifespan. Whereas in a country like India, although in a metropolitan city, we will still have good outcomes, but in all the peripheral centers, it may not even be diagnosed and the baby is just going to die and it will be termed as a sudden cardiac death, sudden infant death syndrome, wherein there was probably some cardiac lesion that went undiagnosed because that place didn't probably have the facilities of knowing whether the baby had that cardiac defect, or it didn't have the mode to correct it, to operate on it. Which is why when I talk of development, the Western countries are going to have a higher prevalence because the patients, the babies who are born with those congenital heart diseases also grow up and those women also become pregnant. Which is why congenital heart diseases are much more common in the West, whereas in our countries it is more of RHD that is common. Okay, so that was the disparity that we spoke of in terms of the location, the residency. Anything about the age and heart disease in pregnancy? Kashish?
Yes, sir. So it is actually the heart diseases are more common, especially the RHD is more common in the younger age group. It starts from the young age and then it presents in the later on ages. And pregnancy is already a very hypervolumic state, which can exacerbate the cardiac causes or diseases.
Okay. You are going towards a topic that may not strictly be on the obstetric side of things. You just mentioned that the increasing hyperdynamic status is going to worsen heart diseases. I have a very clear question for you. Are you sure that all the conditions that lead to, I mean, all the conditions, first of all, there is a hyperdynamic circulation in our body during pregnancy. So are all the heart diseases worsened by that?
So most of them do.
Okay, fine. I'll come to this later. Given that you have just mentioned about the hyperdynamic circulation, could you tell me what are the physiological changes that happen to my cardiovascular system during pregnancy?
Yes, sir. So first, there's hypervolemia which occurs. Then there is tachycardia. There is a shift in the apex beat. It shifts to the fourth intercostal space. Normally, it is found at fifth intercostal space. Then there is normally we usually don't hear a murmur, but in pregnancy there's a continuous murmur or a mammary murmur that can be heard. And
I would just want you to wait. Are you sure that the murmur that I'm going to be hearing in pregnancy is always going to be a mammary murmur? Because many women in India do not really have great, excessive amount of breast volume. So mammary murmur is not the actual murmur that I would hear in a female with heart disease in pregnancy. Anyway, coming back to you mentioned that the cardiac output increases. Could you tell me why does it increase?
yes, sir. So basically what happened is um so could you just give me a second, please? I'm so sorry.
Okay, Rajlakshmi, would you want to attempt it?
Yes, sir. Sir, the cardiac output increases because there is in pregnancy there is hypervolemia, and also the heart rate increases. So as cardiac output is equal to HV into heart rate, so there is an
Okay,
increase.
so I'll come down a level further below. Why should the heart rate increase and why should there be hypervolemia in pregnancy? Kashish, Rajlakshmi? Okay, I'll answer that. First of all, regarding the heart rate. So we all know that during pregnancy, the major hormone that is present in my body happens to be progesterone. Now, progesterone has a smooth muscle relaxing action. So, when I say smooth muscle relaxing action, I intend to say that every single smooth muscle in my body is going to get relaxed. And it also includes my blood vessels, my arteries, and all my blood vessels, which leads to relaxation of those smooth muscles. Now, this leads to dilatation of the blood vessels in my body, and that also leads to a slight drop in the diastolic blood pressure in my body. The total peripheral vascular resistance is going to reduce slightly. Now, to counter this reduction in the blood pressure, slight reduction in the blood pressure, as a reflex, my body is going to resort to something called as tachycardia or reflex tachycardia. So this reflex is why my body is going to start showing tachycardia. Now, a tachycardia, basically a rise in the heart rate of around 10 beats per minute, is going to be normal during pregnancy. So a heart rate of around 100 is going to be okay during pregnancy. Talking about why should there be an increase in the stroke volume, or basically increase in the hyperdynamic circulation, why should there be hypervolemia? So you already know that in our body during pregnancy there is excessive blood that is going to be going towards the kidneys. First of all, because of the vasodilatation, there is going to be slight reduction, in fact, to the blood supply to the kidneys. Now that leads to an increase in the production of renin and angiotensin. So the RAS cycle is activated, and that RAS leads to water retention. So wherever there is going to be water retention, it is going to start accumulating throughout the pregnancy, and hence by the time my pregnancy has reached around 32 34 weeks of gestation, there is going to be 40 to 50% increase in my blood volume. Now, whenever there is an increase in the blood volume, remember that it is putting up a stress on my ventricles, because now it has to pump much more amount of blood outside of my heart. So for this, there is also going to be compensatory hypertrophy of the muscles in my ventricle, and that left ventricular and in fact even right ventricular hypertrophy is also going to aid in increasing the stroke volume. So the stroke volume is increased because of two factors. First of all, increase in blood volume, and secondly because of increase in the muscle mass of the ventricles, whereas heart rate is going to increase because of the reflex tachycardia. Okay, fine. So this was the physiological change that you were speaking of. We were talking about the murmur. Could you just tell me again which murmur that you were talking about? It is not the mammary murmur, or what we also call as the mammary souffle, that is the prominent one. What is the cause of that murmur? By the way, if anyone in the audience also knows, they can answer it in the comments. That's absolutely fine. So yeah, Kashish, Rajlakshmi, would you want to attempt that again?
So, mainly, there's a systolic murmur that can be heard during the pregnancy, and that is actually due to decreased decreased blood viscosity.
Okay, something better, a little better than that. You just answered the main reason as to why in my body there is hyperdynamic circulation. So if there is hyperdynamic circulation and the entry of the aorta is still the same, the entry of the mitral valve annulus is still the same. So when a larger amount of fluid is flowing to the same diameter, that is going to lead to a murmur. And that is why we are going to have an increased grade of systolic murmurs in the body. Also, apart from that, because there is a large amount of blood that is coming in my ventricles, it leads to sound that is created from the ventricles called as a ventricular gallop. This is also your third heart sound, or the S3 that you hear. So having S3 and also having a systolic murmur up to grade 3 is going to be okay. It is going to be physiological. Whereas if you have any diastolic murmur of any grade, that is going to be pathological. So that is the reason. Basically, your increased blood volume in the body is going to be the reason you're going to have those murmurs, because there's a large volume of blood flowing to the same annulus, your aortic annulus and your mitral annulus. Okay, fine. So proceeding to your LMP and EDD, which is the formula that you have used?
Glaze formula have been used.
Okay, Negli's formula has been used. Great. So she is 36 weeks and 1 days. Okay, her obstetric score is Gravida 3, Para 2, Living 2. Okay, fine. Could you take on to the next slide? So she had chest pain and breathlessness. Now, very classical heart disease complaints. Now, could you tell me what are the signs and symptoms of heart disease in pregnancy?
So in symptoms, there can be dyspnea, chest pain, orthopnea, paroxysmal nocturnal dyspnea, and non-dependent edema. And
Okay,
in
great.
signs, there could be clubbing, cyanosis, murmurs can be heard.
Which murmur? Could you be a little more specific about the murmurs?
Dystonic murmur.
Okay, diastolic murmur is pathological. Anything else? Systolic murmurs?
Ejection systolic murmur.
Ejection systolic murmur? No, I'm not talking about the type of murmur. I'm talking about the grade of murmur. From what grade? And what is the naming of this grading? Above grade 3, great. What is the name of this grading or of this staging? Actually, it is grade 4 and more, but okay, more than 3 is also an acceptable answer. But okay, what is the name of this grading? So the name is going to be Levine's grading. Now, this is a question that you'll also be asked in your medicine exams. So Levine staging or Levine grading of murmur. Okay, that's fine. We were talking about all the signs and symptoms. So you mentioned that for everyone else, what she has mentioned is absolutely correct. The symptoms that you are going to be having, symptoms are basically those things that the patient is going to tell you, whereas signs are those things that the doctor is going to find himself or herself. So the symptoms of heart disease in pregnancy are going to be PND, orthopnea, chest pain, transient ischemic attack, and occasionally hemoptysis. Whereas the signs, as she has mentioned, are going to be clubbing, cyanosis, more than stage 3 or grade 3 of systolic murmur, diastolic murmur of any grade. Anything else? Anything else? Just one more thing. Anything about the lungs?
So could it be pulmonary edema or congestion?
Yes, pulmonary edema. That is, what is it going to give rise to? What sign exactly on the basal areas?
Creps.
Yes, basal crepitations. What are the type of crepitations that you will find in pulmonary edema because of the heart? Cardiogenic edema. Is it going to be fine or is it going to be coarse crepitation?
Coarse crepitations.
Are you sure? When does the coarse crepitation occur? Coarse crepitation is going to be classically occurring whenever there is excessive thick mucus that we associate with infections, LRTI. Whenever there is anything cardiogenic, there is just water, and water is going to give you fine crepitations. So coarse is going to be more so with any infective cause, LRTI, whereas fine is going to be with water, that is your cardiogenic cause. Okay, fine.
Okay.
So your patient had chest pain and breathlessness. That's fine. Okay. Now that we are anyway talking about breathlessness, what do you call breathlessness in pregnancy or breathlessness with heart disease? What is the scientific term for it?
So dyspnea.
Dyspnea, yes. So do you have any grading for dyspnea? And have you done it for this patient?
Yes, sir. There is a grading, NYHA grading, New York Heart Association grading
Okay.
in cardiac cases.
Okay, what is the stage of your patient? Could you go on to the next slide as well? Okay, so could you tell me, it was grade 2. So could you just quickly tell me what are the gradings? What are the stages of NYHA?
Yes, sir. So grade 1, there is no dyspnea. Grade 2, there is dyspnea with ordinary activity. Grade 3, there is dyspnea on less than ordinary activity. And grade 4 is dyspnea at rest.
Okay, very good. So your patient had dyspnea with just ordinary activity. Okay. Is there any other grading or staging that we have for heart disease in pregnancy apart from NYHA?
The WHO.
WHO classification, very good. So could you tell me what is the difference between WHO classification and NYHA classification?
So in the WHO, mainly, it is more related to the pulmonary.
No. Anybody else, by the way, who would want to attempt this? MMRC is definitely not for heart disease in pregnancy made. No, absolutely not. Kshitij, yes, WHO risk stratification, very good. But what is the difference between NYHA? Yes, WHO gives morbidity and mortality, but anything more? I just want a better answer. I just need one word as an answer. Rajlakshmi, any idea? Any thoughts on this? What is the major differentiating point?
So NYHA mostly is for the heart failure, for the grading of the heart failure.
No, absolutely not. So NYHA is more as a functional classification. It tells you about what are the functional limitations that you're going to be having because of any particular heart disease. Whereas your WHO classification is more on only etiologies. Etiology matlab, if you have something like tetralogy of Fallot, then you are definitely in WHO class 3. If you have a repair tetralogy of Fallot, then you become WHO class 2. It does not matter then what are your symptoms. So your signs and symptoms are going to be done for NYHA, and whereas your etiology, what is the cause, what is the lesion, that is going to be specified on WHO. So basically WHO is an etiological classification wherein they just list out the various etiologies and its risks for death and morbidities, whereas NYHA is only for your functional limitations. Okay, so fine. That's the difference. So in your case, what do you think might be the WHO grade for your patient? Kashish, Rajlakshmi, any idea what might be the WHO grading for your patient? Also, others in the attendees, anyone who would want to answer this one? Kashish, are you online?
So could it be second because it is
Yes,
an
it is. It is
unobstructed
absolutely,
case?
absolutely. So it is second stage, and that's good. That's pretty good. Yes. So could you tell me what is the difference between 1, 2, 3, and 4? A basic difference. And
So
contraindication कौन से वाले में होता है pregnancy?
Grade
uh,
4.
Yes, grade 4 is contraindication. So basically, there are so many etiologies. You do not need to remember किसमें कौन सा है. All you need to remember is category 4, that is WHO class 4, because those are the conditions wherein pregnancy is contraindicated. Could you just briefly and quickly tell me what are the class 4, WHO class 4 disorders?
So if there is pulmonary arterial hypertension or Marfan syndrome with aorta dilated more than 4 centimeters, or
Okay.
there could be
severe mitral
It is
stenosis.
actually not 4, it is 4.5 centimeters. For more than 4 becomes category 3. But that's fine. At your level, that is acceptable. Anything more?
So severe mitral stenosis, and there could be previous any peripartum cardiomyopathy.
Is it peripartum cardiomyopathy or peripartum cardiomyopathy with residual dysfunction?
With residual dysfunction.
Yeah, so if your residual dysfunction, basically ejection fraction, which ideally should be around 55-60, is still less than 30 in your
Yes,
current pregnancy, then it becomes category 4. So with reduced, so PPCM सिर्फ हुआ है तो that is not an issue. If it is reduced, अभी भी, then it becomes category 4. Okay, great. Fine. So these are your category 4. Pregnancy is contraindicated, and if you do get pregnant with category 4 or class 4 WHO, then you have to consider MTP. And if the patient doesn't opt for MTP, then you have to keep that patient admitted in the ward till she delivers. So that is a bare minimum prerequisite. Okay.
yes, sir.
Okay, fine. So chest pain was acute in onset. It was squeezing, central, non-progressive and non-radiating, aggravated on bending forward and relieved on lying down. No medications were taken. That's fine. Okay, you can go on to the next one. By the way, you just mentioned about all the pathological signs and symptoms. Could you tell me what are the physiological signs and symptoms of pregnancy? Something related to the heart because of your hyperdynamic state and gravity uterus. What all things would you see physiologically? That shouldn't be mistaken as pathological. Non-progressive dyspnea, yes. Pushpa, correct. So just mild grade breathlessness. What else? Why should there be breathlessness in pregnancy, by the way, even physiological breathlessness, Kashish?
So because of the increased, so as it is a hypervolumic state, there's an increased cardiac load on, there's an increased load on the heart for the pumping, and more volume of blood is pumped through the atria to the uh, lungs, and there is also the cause can be because of the distended uterus, the
Yeah,
diaphragm gets
exactly. Distended
uh,
uterus is the biggest cause in second and third
diaphragm is
trimester.
pushed upwards,
Yeah, it is
and
pushed upwards. The lung volume basically reduces, which is why it gives you a sensation or a perceive. You perceive breathlessness, though it may not actually be affecting your lung function much, but it is the pushing of your lung fields by the uterus. Okay. What else? One is low-grade breathlessness. Apart from that, swelling of feet, that is your pedal edema. And apart from that, your signs are going to be a bit of shift in the apex beat and also systolic murmur up to grade 3. That these are your physiological changes. Okay. In your history of presenting pregnancy, anything significant here? You have mentioned that she is taking aspirin and ecospirin. Is there any difference?
given so she was first she was given aspirin before. They are the same actually, so I just
Yeah, it is just
mentioned
a
both of
brand
them.
name. Yeah, it is
Yeah,
just
I
a
just
brand name.
mentioned both of them.
Do you believe there is any role for aspirin in this patient?
So I don't think so. It should have been maybe a, a low molecular weight heparin.
Acha, low molecular weight. What is the parity score that you told me?
Parity score is 2.
No, no, parity score is basically not para. I'm asking what your entire parity score is. Gravida 3, para 2 living to,
Florida
right?
3 yes sir.
Okay, so she is not even having any bad obstetric history. Do you really think aspirin was indicated for her?
No sir.
Okay,
But she is also like hypertensive, so maybe to as a prophylaxis to prevent
okay, that's a good point that you have made.
eclampsia.
She's a hypertensive. Is she a preeclamptic or is she a chronic hypertensive?
She is a chronic hypertensive. She was
Okay,
diagnosed 1 year back.
okay, so she is still a hypertensive. So in chronic hypertension, why do you give aspirin?
So to prevent preeclampsia, eclampsia.
Okay, good. That's a great answer, actually. So, could you tell me how will it prevent? This is something that we'll be discussing more in hypertensive disorders of pregnancy. But could you just tell me why should that lead to reduction in the chances? Kashish, Rajlakshmi. Okay, so the thing is, in chronic hypertension, when you have been having hypertension in your body since a long time, basically that is going to lead to damage of your endothelium because of the hypertension. Shearing force is going to damage your your endothelium. So whenever there is damage to the endothelium, it leads to endothelial dysfunction. And endothelial dysfunction in the body, especially in the spiral arterioles and all those areas of the placenta, is going to predispose that female to preeclampsia. So you cannot stop that shearing off because it may have already happened because she is a chronic hypertensive. But what you can do is the consequence or the sequelae that happen after that endothelial dysfunction occurs. So basically, that is going to lead to multiple small platelet plugs that are going to be formed. So basically, that is going to be prevented by your aspirin. So the antiplatelet action and the vasodilating action of your aspirin is going to be useful in preventing. What is the dose of aspirin that you give for this indication? Kashish, Rajlakshmi, anyone?
So from
Mm,
75 to 150 micrograms.
okay, very good. What do you call it as? Low dose aspirin.
So
Okay, fine. Continue. So anything significant in your history of presenting pregnancy?
no sir, apart from the main chief complaints, there's nothing much.
Okay, your female is a 33-year-old female with chronic hypertension. Could you just quickly tell me she's a relatively young patient? So what can be the causes of hypertension in such a young female? Just two, three causes.
It could be
Yes.
any pre-existing conditions. Like, for example, she is a known case of RHD. It could have lead to that.
Will
And
RHD lead to hypertension? Absolutely not. RHD is only affecting the valves. It is never going to lead to hypertension. Anything else? Yes, everyone has answered it correctly in the answers in the chat. Anything non-cardiac cause like renal artery stenosis or any connective tissue disorder like SLE, Apla syndrome, absolutely, or any endocrinological cause like pheochromocytoma. So that is going to be your homocystinemia. So hyperhomocystinemia. These are the various causes that you would want to look for once at least, given that she is a hypertensive at 33 years of age. Okay, fine. So her ultrasound was done. CA presence. What is CA? Cardiac activity. Okay, cardiac activity was present. Okay. Next slide. Okay, nothing significant over here either. Next. Okay, so she has been consuming these drugs. Okay. Now you believe your patient is a known case of heart disease. Do you expect any other drug that she should have been on?
So, anticoagulants,
Okay, which anticoagulant?
low molecular weight, heparin and warfarin.
Okay, what is the indication? Which is that exact heart condition in which you will be giving anticoagulation?
so in any surgeries, mechanical valve surgery.
Okay, very good. Mechanical valve, or more classically, your prosthetic metallic valve. In a patient with metallic valve, they'll be kept on anticoagulation. But your patient, I don't believe, has a valve, right? Metallic valve.
Yes, sir. There's no valve present.
Yeah, exactly. So, should she be on an anticoagulant?
No.
Okay.
But
So, yeah,
uh,
yes.
maybe prophylactically because she's already um, hypertensive.
No, I mean, why would you give anticoagulation to a hypertensive? There is absolutely no need. In fact, anticoagulation has a lot of drawbacks, and you would want to prevent giving them to the female as much as possible. So, okay, not anticoagulant, but any other drug that you believe she should be on, she could have been on. I believe your case is a case of mitral stenosis.
So antibiotics.
Okay, very good. Antibiotic. Which antibiotic to be more specific?
So
So,
penicillin.
penicillin.
Penicillin, okay. Penicillin, very good. Penicillin, could you just tell me the regimen in which we'll be giving them?
So, at the intervals of 4 weeks throughout the pregnancy.
Okay,
And
4 weeks throughout. Is it 4 weeks or is it something else? What is the exact time interval? 21 days, very classically given in Harrison's as well. You'll be giving it every 21 days. Nowadays, you also get tablets of penicillin, which you can be taking every day. We call it tablet pented. It's a brand name, and it is in the dose of 400 milligrams that you will be taking every day, twice a day. Okay, so that is one of them. Any other drug? Penicillin prophylaxis chhod ke any other drug? Two drugs, two important drugs, especially in patients with mitral stenosis. Yes, Reshma, correct. Kashish, Rajlakshmi, I would want you to answer it just before the people in the audience answer. Anish, yes, I have read your questions. I will answer all of them. Don't worry, I've read all your questions. I understand. I'm not going to ignore them. I'll answer each and every question of yours. If not here, at least on the chat. Don't worry, answer ho jayenge wo. So yeah. Um, so one of the drugs that Reshma has mentioned is a beta blocker. Which is the classical beta blocker that you give for heart disease in pregnancy? Labetlol, Mohak. I believe you are from KEM. Oh, I think you were also one of my students. That's a very pathetic answer. Labetlol is an alpha and beta blocker. It is an antihypertensive. I need to give a cardioselective drug that happens to be metoprolol. I need to be giving something that is beta 2 receptor specific, that is my cardiospecific drug, and that is metoprolol. Could you tell me, this is a very important question, Kashish and Rajlakshmi, could you tell me why is beta blocker essential in heart disease in pregnancy? It is not for hypertension. A cardioselective drug, why is it important?
So, am I audible?
Yeah, you're audible.
Okay. So because it will help in block the adrenaline, which will adrenaline, noradrenaline, that is the major work for the beta blocker, that will reduce the heart rate, decrease, because tachycardia is present in pregnancy. So it will decrease that, and palpitations which will be present,
Very
that will
good.
be
Good.
reduced.
You mentioned reduction in the tachycardia. That is the exact answer that I was looking for. Could you tell me how reduction in the tachycardia is going to help our patient? Yes, Chinu has answered that correctly, and the answers that it is going to increase the diastolic time. So there is going to be more time for the blood to accumulate in the heart and then pump it out. On the other hand, if I'm not preventing tachycardia in pregnancy, then my ventricles are not going to be completely filled. There is going to be increasing back pressure changes, and that is going to lead to pulmonary edema and signs of congestive heart failure. I do not want that, which is why I need my diastole to be adequate enough, and hence I need those beta blockers and cardio specific beta blockers to be specific, and not labetlol. It has to be metoprolol. Okay, one more last drug that is very important: heart disease in pregnancy, mitral stenosis. One drug, one class of drug, very important. It will reduce your preload. That's your hint.
Sir, diuretics,
Excellent answer. Diuretic. Which diuretic to be specific?
furosemide,
Very good. Lasix, which is the brand name, or furosemide is given. Very good answer. We often give it to patients with mitral stenosis, but not with aortic stenosis. Of course, you also know that aortic stenosis can happen in a patient with RHD, but we give it only in patients with mitral stenosis. Why?
So because it may reduce cardiac output.
In aortic stenosis, very good. So I do not want the cardiac output to reduce in a patient with aortic stenosis, because jitna hai, that is the one that is keeping the baby alive. So I do not want to reduce it. Then why give it in a patient with mitral stenosis?
So that there's no congestion and there's no heart failure.
Very good, excellent. So to reduce the preload so that there is no chance of having any signs of heart failure. Okay. Now that we are anyway on drug and treatment, and a student Anish is consistently asking, that was anyway going to be a topic of my discussion, I would want to talk a bit on anticoagulants in pregnancy. Now assume that your patient had mitral stenosis and she had a metallic valve replaced in her. Now she has a metallic valve in situ. So which is the anticoagulant of choice in your patient in that case?
So warfarin should be the answer. Because
Very
then
good.
after that, we'll change it to low molecular weight, as it can be toxic to the fetus.
Acha, okay. Is it toxic to the fetus? What do the latest 2018 European Society of Cardiology guidelines say? In fact, that is also one of your neat potential questions or neat concept, I would rather say. Is warfarin any longer contraindicated in pregnancy? Kashish or Rajlakshmi? Am I audible? You make me doubt if I am audible.
Yes, sir, you're audible.
Okay.
So warfarin is not contraindicated in pregnancy, but we don't prefer to use it in first trimester.
Okay. So the thing is, this was the case until even my undergraduation took place until 2018, 2019. But in 2018, there has been a new guideline. Now, see, LMWH is a good drug, but first of all, the cost of one LMWH injection is around 100 rupees. So that is one big factor in a country like India. If she has to take it throughout pregnancy, which is around what, 280 days, 280 into अगर 100 करोगे 28,000, not possible, not feasible. Warfarin, in comparison, costs you somewhere between 1 to 1.5 rupees only, one tablet. Secondly, warfarin is a much superior drug when it comes to anticoagulation. So even with one dose, you can have your INR around 2.5, 3, 2 to 3 के बीच में, जिसमें अपने को maintain करना जरूरी है. So that is why it is a superior drug. But the concept was that it was leading to warfarin embryopathy and very classically chondrodysplasia punctata. That was a very classical lesion. So how do you, by the way, diagnose chondrodysplasia punctata? It's a gold medal question. It's a higher order question that you would be asked in your exams. Do you have any idea what do you see on ultrasound for chondrodysplasia punctata? Any idea?
Sorry, sir. I don't really have any idea
That's
about
fine.
that.
It is chondrodysplasia punctata. Basically, chondro is your cartilage, punctata, basically stippling of your cartilages. So instead of what Kshitija said, no carpal bone, instead carpal bone being visible in your antenatal scan, your second trimester TIFA scan is indicative of chondrodysplasia punctata. So that is indicative of warfarin toxicity. But now it has been shown through studies that any dose of warfarin at less than 5 milligram per day is safe across all trimesters, including first trimester. So you do not need to worry about that. Okay. So you can take warfarin only if your INR is not maintained between 2 to 3 and you have to step it up beyond 5 milligram per day is when it becomes teratogenic. And in that scenario, you would want to start her on LMWH. So don't worry about it. You can give it. Warfarin is a safe drug to give. Is warfarin safe to be given after 36 weeks?
No, sir. Then after 36 weeks, low molecular weight heparin is given.
Okay. Why would you want to give that? Am I audible?
So, am I audible?
Yeah, you're audible.
So, it can cause increased risk of PPH, postpartum hemorrhage, and with that, it also um, crosses the placental barrier.
Okay, very good. You're coming very close to the exact answer that I seek. So what will happen if it is crossing the placental barrier?
Sir, it will cause intracranial hemorrhage in the fetus.
Okay, very good. Good answer. So basically, your LMWH does not cross your placenta because it's a large molecule, whereas your warfarin is going to cross it, and it has a long half-life. So your baby is going to be anticoagulated for at least 8 to 10 days after your last dose of warfarin was taken. So You would say, why not just correct it? I can just give FFP or cryoprecipitate and correct it. Remember, again, FFP and cryoprecipitate are large molecules that are not going to be crossing the placenta. So they cannot correct the fetal anticoagulation. They can only correct maternal anticoagulation. And hence, that also becomes a direct indication for cesarean section. A patient who is actively in labor and was consuming warfarin until recently, that patient has to be taken for cesarean section. How many weeks of gap has to be given at least after your last dose of warfarin before you can safely proceed with normal labor? What is the duration, bare minimum time?
2 weeks.
Correct, 2 weeks. 14 days is bare minimum, after which you can safely give trial of labor. So at 36 weeks, it becomes imminent or very pertinent, in fact, that you stop warfarin and shift her to LMWH. Okay. Do you know how is LMWH given? What is the mode of administration?
No, sir.
Okay, it is given subcutaneously. You give it subcutaneously, and that is the way to give it. If you are giving it prophylactically matlab the patient is not giving you any history of deep vein thrombosis, then you give it once a day. If there is any history of deep vein thrombosis or any ischemic event, then you give it twice a day. That is your therapeutic regimen. Okay. How long before your cesarean section or vaginal delivery do you have to stop LMWH?
Before 12 hours.
12 hours, okay. And if it is a therapeutic dose, that is twice a day, then it is 24 hours.
24
Single
hours.
dose agar hai, yeah, 24 hours, correct. And what about unfractionated heparin? By the way, Uzma, the dose that you're saying, 5,000 international units, is for unfractionated heparin. Do you know, Kashish, the dose for LMWH? Yes, Preeti, that's the correct answer, 40 milligrams. So it is weight based. If your weight is below 50 kgs, then you give 20 milligrams between 50 and 90, in which most of our women fall in. That is 40 milligram. 90 to 120, it is 60, and more than 120, it is 80 milligram. Okay. So that is about anticoagulation. Could you just briefly tell me about what is bridging thromboprophylaxis?
Sorry, sir, can you repeat?
Could you tell me what is bridging thromboprophylaxis?
Sir, I have no idea about this.
Okay, fine. So there's a problem with warfarin. The problem is that whenever you start any patient on warfarin, in the initial 4 to 5 days, it will have a hypercoagulating action. Why? Because it is going to inhibit protein C and protein S. Protein C and protein S are your body's normal physiological anticoagulant agents. So if it is going to inhibit an anticoagulant in your body, it is going to lead to hypercoagulation. So the risk of DVT increases in the first 4 to 5 days of giving warfarin. So in those 4 to 5 days, I also need another substitute anticoagulating agent like LMWH or unfractionated heparin to be given simultaneously. This is called as bridging thromboprophylaxis. That is to prevent any DVT. I'm bridging two drugs. After 4 to 5 days, I will stop LMWH or unfractionated heparin and I'll just continue on warfarin. But the same thing need not be done when you're doing this at 36 weeks. Why? Because wahan pe you are stopping warfarin and you are continuing LMWH or unfractionated heparin. So it is the other way around. After delivery, when you're starting warfarin is when you do this bridging. But before that, you do not need to keep both of them on together. You can stop warfarin and immediately start on LMWH. You do not need to do bridging before delivery, because at that point of time, you are stopping warfarin, and warfarin being a longer half-life drug is going to last in your body for the next 1 to 2 weeks at least. So this is about thromboprophylaxis. Could you go on to the next slide? Okay, obstetric history, nothing significant over here. Next. Nothing significant in your first trimester, second trimester, and your third trimester history. That's fine. Next, history of previous pregnancies. Again, nothing significant. Now that we have come to history of previous pregnancies, you have also mentioned about uh, the cesarean section. First of all, whenever you mention about cesarean section during your obstetric history, always mention the indication for what it was done. So only when you mention that the reason why the cesarean section was done, it may have been related to something about a heart disease. Maybe she had an episode of heart failure or something. You never know. So you would always want to ask the indication. Do you know the indication?
So we tried to ask her, but she said she doesn't remember about that.
Okay, fine. No issues. Fine. So apart from that, nothing significant. Could you tell me now, this patient, her known case of heart disease, can you give her a VBAC?
So sorry, can you please repeat?
Could you give this female a VBAC, that is vaginal birth after cesarean, or TOLAC, that is trial of labor after cesarean? Can you give her a VBAC?
Yes, sir.
Okay, good. So could you tell me what are the indications in which I would not want to go ahead with the vaginal trial? Non-obstetric, cardiac indications.
So if the patient was on warfarin,
Okay, yes, one
and
of them.
if there are any aortic aneurysms or coarctation of aorta,
Okay,
severe aortic stenosis.
okay, very good. Even severe mitral stenosis.
Eisenmenger's syndrome.
Okay, Eisenmenger syndrome, very good. Anything more? One more last indication, just one more. Something about the pulmonary system.
So pulmonary artery hypertension.
Very good. Severe pulmonary artery hypertension. Even a few people, even with mild, they prefer to give cesarean section, but I personally prefer moderate and severe. But yeah, pulmonary artery hypertension is good enough as an answer. Okay, so anything that is in class 4 is going to have class 4 WHO is going to have a cesarean section directly. Nothing, no fooling around with a vaginal trial. Okay, assume that your patient is in labor now. What are the precautions? What are the intrapartum precautions that you will take for her?
So we'll give prophylactic antibiotics.
Okay.
Then in in the labor when she
Yes, continue.
so the fluid management and the position.
Okay, the fluid management and the position. Okay, what exactly fluid management wise?
So we shouldn't be infusing more fluid, like more than 75 ml, because it will lead to congestion and heart failure for the
Okay, that
pulmonary
is for
edema.
mitral stenosis or for aortic stenosis, 75 ml per hour.
So for mitral,
Okay, very good. And for aortic? Any idea about why is Swati raising a hand? She can directly ask her out in the comments. Okay. Anyway, so in aortic stenosis, how much would you give? Would it be more or would it be less? And why? Okay, so the
So
answer
we
is yeah. Tell me, Kashish, tell me, yes.
so it might be wrong, but I feel it should be less because we uh there already be more volume.
Okay, so the thing is actually in aortic stenosis, the point is that you have to forcefully open your aortic valve so that you can send the blood outside. So when you have to forcefully open it, you would in fact need a little more fluid coming through so that it can pressurize and open up the valve. So it is the other way around. In a normal patient without any cardiac disease, the fluid rate is 100 ml per hour. In a patient with mitral stenosis, it is 75 ml per hour. And in a patient with aortic stenosis, it is going to be 125 ml per hour. It is more. It is the only condition, in fact, wherein you will be giving more fluid than any other condition. So it is to just forcefully open the aortic stenosed, the stenosed aortic valve. Okay. What else? What are the other precautions that you'll be giving? One is your position. You'll be trying to keep it in left lateral position so that there is no aortocable compression. Correct. What else? And IV antibiotics. Okay. Would you want to do an
Yeah.
early RM or late ARM, or it doesn't make a difference? There's one more thing that people are answering, epidural analgesia. So epidural analgesia, that's a good answer, but it can be dangerous in which type of heart disease? Kashish, Rajlakshmi, any answers? Okay, so the thing is, whenever you have any patient with aortic stenosis, remember your epidural, any regional anesthesia, regional is epidural or spinal, is going to cause hypotension. Hypotension, as I've just spoken, is not a great thing to happen for a patient with aortic stenosis, and hence hypotension, hypo, less, not hyper, hypo, less. Hypotension is to be prevented, and hence epidural analgesia has to be used very carefully in patients with aortic stenosis, and even otherwise. To prevent hypotension, I have to be very careful. I have to attach all the monitors and everything to the patient. I have to monitor them strictly. But yes, epidural analgesia, very important to prevent pain and tachycardia. Okay, so you progress to the first stage of labor. In the second stage of labor, anything more that you will do? Anything different that you will do?
So we'll shorten the second stage of labor by doing forceps delivery or vacuum.
Okay, so you'll cut short the second stage. Why do you have to cut short the second stage though?
So to prevent like cardiac failure.
Okay, good. So basically, whenever a female is going to bear down, the aortocable compression is going to increase even more. And also the pain is going to be more if you have not given her epidural. So that is going to lead to tachycardia, and all the complications of heart failure will start setting in. Okay. Could you tell me what are the variations in the cardiac output that occur during labor? Or is cardiac output constant across all stages of labor?
So the cardiac output mainly starts increasing at 4th to 5th week of the pregnancy, and it keeps on increasing um, till almost 36 weeks of pregnancy,
Yes,
and
correct.
after that, um, mainly when the patient or the pregnant female is in lateral recumbent position, left lateral recumbent position, is where the cardiac output is managed or gets slightly lower.
Okay, but the question is across various stages of labor, first, second, third, what is the variation? So we have just mentioned that cardiac output is a multiplicator, is basically your stroke volume into your heart rate. So remember that every time your uterus contracts in the first, and more so in your active labor, in your first stage of labor, At that point of time, a lot of blood is going to be pushed from the uterus into the systemic circulation. Whenever it contracts, all the blood is going to send back to the systemic circulation. So that increases the blood volume inside your body. That increases your cardiac output. As your labor progresses and you go more towards your second stage, it is not just these contractions which increase in duration, which increase in intensity, but also the pain that increases, and that leads to an increase in your heart rate as well. So your cardiac output increases even more during your second stage of labor, because now even your stroke volume is high because of increased blood volume, and also your heart rate is high because of pain. So it is at a very high volume. Your cardiac output is at a very high level during your second stage of labor. But all of this is even superseded once the baby is delivered, because once the baby is delivered, your iotocaval compression is removed. All your uterus is going to contract completely. So there is something called as autotransfusion. Autotransfusion is basically my own body is giving transfusion, blood transfusion to my own body. So all the blood that was stored in my lower limbs and all the blood that was stored in the uterine sinuses is thrown back into my own circulation, and this is called as autotransfusion, and that leads to an increase in the blood volume by 500 to 600 ml. This increases the stroke volume even further, and my maximum cardiac output is always going to be in the third stage of labor, that is immediately after delivery. So my cardiac output is gradually increasing during pregnancy. It increases more in my first stage. It increases furthermore in my second stage of labor, and it peaks in the third stage of labor. That is during my placental delivery and after placental expulsion. So immediately after delivery, my blood level, basically my cardiac output increases. This can lead to an increase in my cardiac overload, and that can lead to heart failure. How do I prevent this? There is one way that I can prevent this. How?
So can it be uh, a mixture of position change and with the
Any
like
drug that I can give, any drug, one drug.
diuretics, potassium sparing diuretics?
Potassium sparing, oh my god. Anything simpler. Furosemide, you have been using it throughout your pregnancy possibly. Just give an IV dose, intravenous dose. So that जो भी 500 ml excess आ गया था body में, that is going to be immediately removed from the body through urine. So we immediately, after the baby is delivered, always and always in a patient with heart disease, give furosemide, that is a diuretic, for this very reason, to prevent a cardiac overload because of an increasing cardiac output. Do you get it?
Yes, sir.
Yes, sir.
Okay. Next slide. Menstrual history, not significant. Okay, next. Past history, okay, fine. Chronic hypertension, we'll discuss it in hypertensive disorders of pregnancy, not now. Next. Okay, skip this. Come to examination now. Okay, your examination has been fairly normal. I believe you might just have had some variation in your cardiac examination. Could you go there directly? Okay, inspection, chest symmetrical, palpation. Okay. Even I have never had all these things. I never first saw all these things in my own clinical practice, but that's good that you have mentioned them. Okay, that's fine. On systolic murmur, grade 3. Okay, so basically you just heard a normal systolic murmur, nothing pathological. Okay, next. Inspection, abdomen, no. Okay. By the way, regarding inspection, palpation, all these things I'll be talking about in the polyhydramnios session, the classical antenatal examination, not here. Palpation, nothing significant in yours. Okay, fine. Next. Summary, fine. How do you manage your patient? She's 36 weeks now. Last part of the discussion now. How do you manage her? Kashish, Rajlakshmi?
So we'll keep her under constant monitoring with the we'll do a monitoring ECG monitoring, and we'll check for the
ECG monitoring, do you think anything is going to go wrong in our ECG?
Also, there can be, normally there's, in the pregnancy could be PR prolongation.
Okay, but that is physiological. I wouldn't want to monitor it. I would rather just want to admit her, if at all I'm admitting her at 36 weeks, I would want to admit her to have a look at whether she is having any worsening of her signs and symptoms, the pathological signs and symptoms, if she's having worsening of her NYHA grade, or if she's having any problems, the chest pain that you mentioned, that is an indication for her admission. All these things, I'm going to be admitting her to monitor her signs and symptoms and her vitals. That's it, nothing else. Okay, when will you terminate this female? At what weeks of gestation?
So at
So after 37 weeks of gestation.
That is a very generic answer. 37, 38, 39, 40. At what gestation would you terminate her? By the way, for all the participants and rather for all the attendees, there is a link that has been posted by our academic team. You all will have to fill it. It is mandatory so that you all receive your certificates and we can confirm the attendance. It has been posted in the chat. Okay, so 37, 38, 39, 40. When?
So can we wait for the
Spontaneous onset of labor.
spontaneous labor?
Okay, there is a very crucial detail that you're forgetting over here, that your patient is also a chronic hypertensive. All patients with chronic hypertension or preeclampsia will need to be terminated by 37 or between 37 and 38 weeks of gestation. So although your heart disease may preclude, if it would have been just classical heart disease without any other complication like heart failure and nothing, then she could have been terminated at 40 weeks of gestation. Why? Is there any reason why we prefer to terminate all patients without any complications at 40 weeks of gestation, heart disease patients?
Sorry, sir, I have no idea about this.
Okay, anyone else? Okay, so the thing is, if you're going to terminate the female or any female before 40 weeks of gestation, the earlier you terminate any pregnancy, the higher the chance of a cesarean section because of non-progress of labor. So you would want the head to be well engaged into labor, and that would happen only by 40 weeks of gestation. And after 40, there are going to be chances of postdatism, the risks of postdatism. So 40 weeks is that ideal period when I can terminate this pregnancy or any pregnancy with heart disease, so that the chances of cesarean section go down drastically. Remember, cesarean section is a stress on the body. A stress with excessive blood loss, more blood loss in vaginal trial, and also increased risk of infective endocarditis because I'm opening up the entire abdomen. So I wouldn't want that, and hence I would want as much as possible for her to deliver vaginally. So all patients with heart disease without any complications, 40 weeks. If there are complications like heart failure or anything, then I can terminate them at 40 weeks. Then I can terminate it immediately, but not otherwise. For your patient, because she's a chronic hypertensive, that is the reason I would want to terminate her between 37 and 38 weeks of gestation only. I would not want to go ahead because the risks of superimposed preeclampsia, IUFD, all those increase, which is why I'm going to terminate her between 37 and 38 weeks. Okay, so now that we have spoken about all this, one more question. If your patient had any complication that I just mentioned, severe mitral stenosis with pulmonary artery hypertension during pregnancy, what will you do?
So it would come under the WHO grade 4, so we'd go ahead with the C-section and not the normal labor.
Okay, but that is for your pregnancy. What about your heart problems? You have a patient with severe mitral stenosis, and now she's also having pulmonary artery hypertension. So what would you do?
So surgical management.
Okay, surgical management, what exactly?
For the stenosis, we'll put the mechanical valve or prosthetic valve.
Anything that is a little more safer that you would want to do before your replacement? Everyone is answering it correctly in the audience. It is balloon valvotomy. Valvotomy is making a hole. I do not want to make a hole. I'm going to open it up. Valvulotomy. Valvulotomy is basically I'm putting up a balloon inside, and that balloon is going to be opened up. That balloon will ensure that my mitral stenotic lesion is going to open up. But again, remember that is a very temporary measure. If it is done before pregnancy, within a year or two, it can start re-stenosing. And once it re-stenoses, the calcification is so hard that now yet another episode or yet another procedure of balloon valvulotomy may not work. In that scenario, I will have to go ahead with a mitral valve replacement. So mitral valve replacement is only done if my valvulotomy is not going to work, or it has already been done and it has now again recurred. There's re-stenosis. These are the only two indications. So replacement, a very dangerous procedure in that there is a 50 to 60% chance of abruptio placentae during the procedure and the fetus succumbing. So what we do is we do this procedure at 28 weeks. A lot of people do cesarean section at 28 weeks and simultaneously do valve replacement so that even the baby will survive in an ICU setup, and replacement will also be done, and that will lead to a successful maternal outcome as well. Any role for perimortem cesarean section in this, Kashish? What is perimortem cesarean section?
So it's an emergency cesarean section performed if the mother is in the cardiac arrest. To basically to make the fetus live.
Okay, so is your peripartum or perimortem rather cesarean section for the baby or for the mother?
So for both of them.
No, it is for your mother. You do not care any longer about your baby. Remember, with that gravid uterus, giving a CPCR is next to impossible, a good CPCR. You would end up giving a CPCR to the lungs and not the heart because of your gravid uterus. I do not want that, obviously. So I would want to do wherever the patient is lying. Within 4 minutes, the decision for section has to be given within 4 minutes of cardiac arrest, because within minutes there is going to be permanent brain damage. Within 8 to 10 minutes there is going to be hypoxic brain injury to the mother. I do not want that. So within 4 minutes a decision for cesarean section has to be taken, the incision has to be made, and within 6 minutes the baby has to be delivered out. Once the baby is delivered out, you immediately start, the baby survives or not doesn't matter to me anymore. It is for the mother. I will start giving a CPCR. Along with that, I will shift her to the OT. I'll do the closure in the OT, but simultaneously I can give her good CPCR. Also, because the baby has been removed, the iodocaval compression has been released. Once the iodocaval compression has been released, that will lead to much better circulation in the mother as well, and hence the mother is going to have a higher chance of survival. So it is not for the baby. The baby survives, that's a good thing, but it is for the mother. Okay, so that is about perimortem cesarean section and valve replacement. And that is it about the session on heart disease in pregnancy. I'll just move on. I'll give you my opinions about this Viva. But before that, I would want to answer all the questions that were asked in the audience, by the audience. So the questions that were asked by the audience, first of all, Anish seems to be very aggrieved. He has asked many questions, many questions. The first question is, how early in pregnancy should we ideally risk stratify a patient with known rheumatic heart disease, and what are the best systems for doing it? So first of all, Anish, you have to be doing risk stratification prior to pregnancy. Because only if you are able to do the risk stratification before pregnancy, then you can decide on whether there should be an intervention that she should undergo, and if she is capable enough or if she is fit enough to conceive. If she has anyway conceived and she has come to you, your Carprex score is only going to help you determine what are the chances of any cardiac event like a heart failure or a cardiac arrest happening during pregnancy. So all you can do is risk stratification. And if there is a high risk, then you keep the patient admitted. If the risk is very high, then you advise termination of pregnancy immediately. So risk stratification ideally to be done before conception always, be it WHO classification or Carprex score, both of them. The next question was, what was the next question? How early that is done? In patients with mechanical heart valves due to rheumatic, how do you manage anticoagulation during pregnancy, especially in the first trimester, considering both maternal and fetal risk? I have already mentioned how do we use warfarin and heparin. That has been answered already. Apart from that, yes, we have answered that. Any other questions? Kindly put up in the chat so that we can immediately answer them. All I'm seeing are questions from Anish. There are many questions from him. In a pregnant patient with asymptomatic NYHA class A, but echocardiography shows a mitral valve area of less than 1 centimeter square. Should we wait until delivery or intervene during pregnancy? How do you clinically differentiate between normal pregnancy-related breathlessness and early signs? Okay, so this question by Anish says that there is a patient with RHD and she has asymptomatic, that is basically NYHA class 1. But her echocardiography shows that she has severe mitral stenosis. So should we wait or should we intervene during pregnancy? So first of all, a patient with severe mitral stenosis should not conceive. If she wants to conceive, then a BMV, that is balloon mitral valvulotomy, has to be done, and then she can be advised pregnancy. But if she has anyway conceived and if she is asymptomatic, I would want to wait until 20 to 28 weeks of gestation, preferably 24 weeks of gestation, and then I will do a BMV. But if she gets symptomatic before that, then in that scenario, I'll be able to do or I will do a BMV immediately. Obviously, given that mitral stenosis severe है, मैं उसको MTP advise करूंगा, but what I'm saying कि मैं BMV करूंगा is when she declines even MTP. She says that I've become pregnant, I want to take this baby till term. In that scenario, I will wait till 20 to 28 weeks and then do the BMV procedure. It has to be done immediately if she turns symptomatic at any point. But this patient will stay admitted in my ward. How do you differentiate between normal pregnancy-related breathlessness and early signs of mitral stenosis decompensation? So, how do we differentiate? That's a good question. See, breathlessness in a patient with mitral stenosis will not occur isolated way. It will also have things like fine basal crepitations and mitral stenosis wala mid-diastolic murmur. So that is one thing. Secondly, if the breathlessness is there and if the patient is saying there is significant breathlessness, she also faces palpitations, I would want to err on the side of caution and do a 2D echo for her, which will give me the answer whether there is mitral stenosis or not. But remember, mitral stenosis agar hai, especially moderate or severe, she will also have other signs apart from breathlessness, and that is a murmur and crepitations. So yeah, that is important. Next is how is that less than 5 mg didn't cross placental barrier? 5 mg के नीचे जो था वो cross करता था. Remember, the 5 mg dose is only in terms of teratogenicity. Even a dose of 1 milligram of warfarin, which is not given actually, but even a dose of 1 milligram is going to go to the fetus and anticoagulate it. So irrespective of the dose, you will deliver the baby by cesarean section if she is actively on warfarin during the time of delivery. So warfarin at any dose is crossing the placental barrier, but a dose of more than 5 is causing teratogenicity in the first trimester. That is it. So irrespective of the dose, if in the third trimester after 36 weeks she has been consuming warfarin, even if 1 milligram ka dose le rahi hai and she comes to you in labor, you do a cesarean section. Next question is okay, again, how do you, if a echocardiogram is not available, how do you assess functional cardiac status in RHD pregnant patient? First of all, सबसे important thing, you do not manage a patient in a rural area with no access to 2D echo, because this female can die at any moment and you will have no access to an intensive cardiac care unit. So you cannot manage a patient with mitral stenosis RHD in a rural setup. You should not manage it. So we have answered all the questions. I don't believe there are any more questions. During cesarean section in a severe RHD patient, if hypotension is to occur after spinal anesthesia, how would you correct it without worsening cardiac without worsening pulmonary condition? Very nice question, Anish. He has asked that during cesarean section after spinal, if there is hypotension, what would I do? See, if hypotension is occurring in a patient who has been given spinal anesthesia, first of all, that is an indicator that the spinal anesthesia has gone higher than the level that it should have gone. वो थोड़ा L3 L4 से ज्यादा लेवल तक गया हुआ है, what we call as high spinal. So in that scenario, the first thing that I'll do is मैं हेड हाई पोजीशन थोड़ा करूंगा. उसको हेड हाई करने से उसका स्पाइनल जो भी ड्रग्स है वो थोड़े नीचे चले जाएंगे इनसाइड द स्पाइन. सेकेंडली, आई विल स्टार्ट हर ऑन vasopressors, basically drugs that are going to cause vasoconstriction, things like adrenaline, noradrenaline, मैं वो start करूंगा. Remember, not ionotropics but vasopressors that will ensure that the hypotension gets corrected. And after a point of time उसको simultaneously crystalloids भी दूंगा, ensuring कि उसको heart में कुछ ये नहीं आ रहा है, pulmonary edema नहीं आ रहा है. But vasopressors are going to be my answer. When repaired walls, okay, so that is it. All the questions have been answered. I believe there are no more questions. Does anyone have, if in labor, if corrective surgery is to be done, it is to be done at 28 weeks only? Yes, preferably 28, but the window is between 20 to 28 weeks of gestation. The reason is around 28 weeks of gestation, you can do a cesarean section, and if the fetus is delivered at 28 weeks, it is going to be around 1 kg. It will survive. It is going to survive in an NICU, in a good NICU. But obviously, if you're going to be doing a surgery, a cardiac surgery, it will have to be in a proper tertiary care hospital where the NICU is also going to be good enough. So 28 weeks, because that is a point wherein the fetus is also going to be viable enough. Now in India, there are so many fourth generation ICUs, NICUs, jahan pe even 24-weeker baby survives. So 24 to 28 is that window in which you would do that. But if the female is symptomatic, you wouldn't wait. You would immediately do it irrespective of the gestation. So that is it about this session. I hope you all had a great time with this session and you all learned a lot. If there are any doubts, kindly message on the group. Apologies for the inconvenience that was caused initially. That was the first session. It was a little overwhelming. We'll try to ensure that it doesn't happen again. But of course, the group limit is going to stay 150. It's a free session. Remember that. We are not going to be purchasing the Zoom subscription for 600 members because it's a free thing. So please understand. And 150 is a good enough limit. Today we had a group limit of 146. So 150 should be enough. And that is it then. Thank you so much, everyone. I hope you all understood. Could you all just let me know in the comments if the session was helpful or not? And if you all have any doubts, do let me know. Coming back to Kashish and Rajlakshmi, you all were really good. The history has been taken really well. My recommendation, my advice is going to be read a little more into the basic concepts of this heart disease in pregnancy. Apart from that, this is a very tough topic. Honestly, if I was in your shoes, if I was getting a case of heart disease in pregnancy in my final year MBBS exams, I wouldn't have been the happiest person doing that because it's a very difficult topic for undergraduates. So you all did a commendable job. So well done. And of course, I'll be giving you all the scores at the end of all the 12 sessions, but you all did well. And had I been your examiner, you both would have definitely passed. So well done, Rajlakshmi and Kashish. So thank you so much. Kashish, Rajlakshmi,
Thank you
any
so much,
doubts
sir.
that you have?
Thank you so much, sir. This was really insightful. And
Yeah. Welcome. Thank you. Thank you, SIMSOG, for this good opportunity. You've done a great job at managing this session very well. And we'll see again on what, Saturday at 10 p.m. again, every Saturday and Monday. Same session, same time. Let us meet on Saturday at 10. Thank you so much. Good night.
Thank you so much. We're grateful to everyone who tuned in. Do fill out the feedback form and keep an eye out for our upcoming sessions. Until next time, this is the SIMSOG academic team signing off. Keep learning. It is on the chat box, Dr. Shravanti.